Diuretics are one of the main groups of drugs that are used in the treatment of hypertension. They work by stimulating water loss from the body, which reduces the volume of blood in the circulation. With less blood to pump around the body, the pressure in the circulation falls. Diuretics act on the functional unit of the kidney known as the nephron. The nephron separates water, ions and small molecules from the blood, filters out waste and returns components that are needed back to the blood. As arterial blood enters the cortex of the kidney, it passes through the Bowman's capsule, which contains the glomerulus, a tuft of capillaries that filters blood as it flows through. Ions, small molecules and water leave the capillaries and enter the renal tubule, which is formed by a layer of epithelial cells surrounding a lumen. Molecules and cells that are too large to cross the endothelial barrier remain in the circulation, flowing through the capillaries of the kidney medulla to the veins and back to the heart. The fluid entering the tubule passes through the loop of Henle and the distal convoluted tubule on its way to the collecting ducts and eventually to the bladder where it is stored as urine. On its journey, ions and water are reabsorbed into the blood to maintain plasma electrolyte composition and plasma volume. Diuretics interfere with the reabsorption process, resulting in an increased loss of salt and water. Different diuretics act on ion transport proteins located differentially in the loop of Henle, the distal convoluted tubule, and the collecting duct. To help explain how diuretics work, the nephron is now shown stretched out from the Bowman's capsule on the left to the distal convoluted tubule and collecting duct on the right. At most places in the nephron, the walls are permeable to water. So, as ions move across the membranes of the epithelial cells of the tubule wall, water follows by osmosis. In contrast, the walls of the ascending limb of the loop of Henle are impermeable to water, but they remain permeable to ions. Epithelial cells lining the tubule contain a variety of transporters that can remove ions from the tubular fluid. In the thick ascending limb of the loop of Henle, the sodium-potassium 2-chloride cotransporter, or symporter, moves these ions into the epithelial cells. To maintain the cell's ion composition, transporters on the opposite or basolateral side of the cell export the ions to the interstitial fluid. Ion movement is normally accompanied by water to maintain osmolarity, but not here. Consequently, there is a buildup of ions in the interstitial fluid, and the tubular fluid becomes dilute or hypotonic. This is the site at which most of the sodium is reabsorbed from tubular fluid into the interstitial fluid and then back to the circulation. The sodium-potassium 2-chloride transporter is blocked by a group of diuretics known as the loop diuretics. They inhibit removal of ions from the tubular fluid in the thick ascending limb of the loop of Henle, so that the renal fluid is more concentrated as it travels through the rest of the nephron. As it reaches the distal convoluted tubule, which is permeable to water, osmotic forces draw water from the epithelial cells into the tubular lumen. The result is increased loss of salt and water from the body. Salt is also reabsorbed in the distal convoluted tubule, although it is a smaller proportion of the total. Again, it involves transporters in epithelial cells of the tubule wall. In this part of the nephron, sodium and chloride are removed from the tubular fluid into the epithelial cells by a different sodium chloride cotransporter. Note that unlike the transporter in the loop of Henle, it does not transport potassium ions. The sodium entering the cell is removed into the interstitial fluid at the basolateral side of the cell by the sodium-potassium ATPase or sodium pump. The potassium entering the cell through this pump is removed again in exchange for chloride. This maintains the ionic composition and charge in the cell. The sodium chloride cotransporter is the molecular target for another group of diuretics known as the thiazide diuretics. They inhibit the transporter and prevent the removal of sodium and chloride from the tubular fluid, along with the water that would have travelled with the ions to maintain osmolarity. There is therefore increased loss of salt and water from the body. The epithelial cells in the distal tubule and the collecting duct express receptors for a type of steroid hormone known as a mineralocorticoid. The main endogenous activator of the receptor is the hormone aldosterone, produced in the cortex of the adrenal gland. By activating the receptor, aldosterone increases the expression of basolateral sodium-potassium pumps, thereby increasing pump activity. This increases the reabsorption of sodium ions and its accompanying water, while decreasing the reabsorption of potassium ions, which are lost in the urine. The mineralocorticoid receptor is blocked by the drug spironolactone. It prevents the action of aldosterone, thereby causing increased excretion of sodium and water, while preserving potassium ions in the circulation. This drug is therefore known as a potassium-sparing diuretic. The main use of thiazide diuretics is in the treatment of hypertension. They have an additional vasodilator effect that might contribute, but its mechanism is unknown. These drugs are all structurally related bicyclic molecules that contain sulfur and nitrogen atoms in one of the rings. There is a newer group of drugs that are not structurally related, but they do share the same mechanism of action as the thiazides. For that reason, they are known as thiazide-like diuretics. Loop diuretics produce a more powerful diuresis, but are no better than the thiazides at lowering blood pressure. So they are reserved for use in patients with pulmonary edema, heart failure, renal insufficiency, or resistant hypertension. Aldosterone antagonists have a relatively weak diuretic effect, so they are mainly used for hyperaldosteronism in heart failure and resistant hypertension. They are often given with other drugs and can prevent hypokalemia when given with a loop or thiazide diuretic. All diuretics have the potential to disturb the plasma electrolyte balance, especially potassium, and they can cause hypovolemia, leading to loss of renal function. For these reasons, serum electrolytes and creatinine levels are monitored during treatment.